maybe we could have all the panelists resume their seats. We don't have a lot of time, unfortunately, for the general discussion, but let me ask if any of the committee has a question that might go across some of the speakers. Sari?
Yeah, we heard from a lot of the panelists about exposure and about the self-reported nature of exposure, and then we heard from Dr. Garshik and his and the Koutrakis model of estimated exposure. I wonder if there are opportunities to either to exploit the results of those estimates in the other studies, which would go a long way to addressing this issue of self-reported exposure, which we all know has a lot of play in it. Any thoughts on that?
I'll just add briefly. Dr. Garshik and his group with the SHADE study have been really supportive of other research efforts, and in fact, we've included his approach into a current pending DoD application as well. So I don't want to speak for his group, but he has made kind of very clear that they want to make this a resource that's available to a lot of investigators.
I would agree with that. We've been having conversations with Dr. Garshik for the last few years. That with what work and exposure models that his group produces. We definitely want to implement that in the Millennium Cohort and future analyses, and hand in hand with the ILR being available to get to declassified locations and then apply this exposure assessment model as well.
To answer your question, sorry, in looking at some of the outcomes for respiratory symptoms and asthma, it's not like it's null. There's actually a positive signal with wide confidence limits when you look at exposed and unexposed groups, or more exposed, less exposed, arguing that if you can sharpen up the exposure definition, perhaps you'll see more of a signal, which I think is what you're getting at. And I think that there's an opportunity, to maybe standardize the way you take an exposure history in these more clinical studies. Instead of just saying exposed or maybe a general questionnaire, you can actually formalize the location assessment. So in hopes that this might actually give more as a signal later on as exposure techniques mature.
Yeah, it's not only the issue of refining the exposure, it's also the issue of addressing information bias, which is always staring you in the face with self-reported exposure. Right?
So this is a question really addressing to Dr. Morris, but I'd wonder if others would kick in on it. When I look at your PFT data, I don't see much in terms of differences between the groups or differences over the time from deployment to the study. But I wonder, what do you think is a reasonable follow-up time if you're interested in airways disease or emphysema? Some of the data you've collected is just a few years after deployment, and those diseases have long latency periods. There's slow loss of lung function, especially if you're looking at cigarette-related disease. And so, are we capturing that potential?
Wow. If they have, I would say from a clinical standpoint, if they clearly have changes on their PFTs, I would hope that we are following up and evaluating these patients on a regular basis, whether that be every year or every 2 years. Now, how often you do the PFTs just depends on the abnormalities, but I think if we found an abnormality, we should be tracking it and making sure it doesn't change longitudinally, as we know potentially can happen. So I would say that hopefully, at least every 1 to 2 years, hopefully within 5 years, maybe we'll see a difference. It may have to be longer. One of the problems with my cohorts is they've come from all over. I don't really see them necessarily to follow up. They end up in the VA system, and I don't have long-term encounters with these patients. Maybe it just depends if they're in the San Antonio area or not. But a lot of them we refer back to their primary bases, and I don't know what happens to them.
But if I think about smokers and someone who's first exposed at age 20,
Yes.
and I'm going to look for a change in the curve from the predicted value or their baseline. I mean, it's often 15 or 20 years, and so I guess I'm not surprised by the fact that you're not seeing the curve separate. But what are the plans really for follow-up of those long-term surveillance in terms of lung function?
Right now, I'm sort of at a quandary because we're not getting any money from the DoD right now. There's no plan in place to follow them. One of the things that I've discussed with all my VA colleagues is being able to take the data that I have from the DoD and follow that into the VA. And there's not a good way to do that right now. There are some examples of that out there, but it hasn't happened from our standpoint, at least crossing over from the DoD to the VA side.
Can I make a comment about that? I think there are opportunities, I think, to use the VA medical record data to get at some of the longitudinal aspects of this. One of the challenges is, however, that not all of the pulmonary function test data are in a structured format. And so, we're looking at using some natural language processing and machine learning to see if we can extract some of the core metrics from the pulmonary function tests that may be stored either in the free text or even in some of the images to create a data set that actually allows us to look over time at the pulmonary function test information as it's recorded in the VA. There is some hope that we would be able to pull in the DoD pulmonary function test data as well, because that's becoming more easily available to us on the VA side. But I think there's a lot of development that needs to happen in order to do that. But then that would be the one way to look at it on a larger scale.
It seems to me that's a very important issue if you're going to make decisions in terms of changes in lung function, being able to go from soon after deployment to 15 years later and having that that ability to look at whether there are real changes or not.
Yeah, and this is one of the difficulties we have. Actually, our PFTs do not link in with ALTA. Our EMR, we actually have to scan them on a PDF and throw them in there. And eventually, we're all going to be one big system eventually, but I'm sure we're probably 10 years away from actually being able to see all the records.
Well, and the data won't be
Yeah, right.
uploaded into
Right.
the new system. So we'll have this legacy system, and if you want to use the information that's there, you'll have to go to get it there. The other way I think we're addressing this in our DoD funded project looking at possible blast injury, we are focusing on patients that have been evaluated already at the risk in New Jersey, and then bringing them back in, and they're going to be stratified by no blast exposure, mild or one time, and then moderate or frequent exposures to blast. But we will, on a cohort of about 90 people, we will have at least 2 data points then for objective, not just pulmonary function test data, but also cardiopulmonary exercise testing, the FOT, all the things that Dr. Falvo was talking about.
Panel, Cecile?
I can't operate the microphone without my glasses, unfortunately. As Dr. Morris had suggested, there is a need to follow up with the STAMPEDE study because of its excellence and its broad base of foundational data. Dr. Roll had commented that VA and DoD are collaborating on data exchange in the Millennium Cohort Study. And this isn't the only example where VA and DoD collaborate in research. We also work very closely with our DoD colleagues in defense health and force health protection historically. So, I'm hopeful that because we have good interagency communications and collaborations established, that the future of STAMPEDE would, in fact, find a home in VA. We don't have that yet, but I'm hopeful.
Another question for the panel, Cecile?
I can't operate the microphone without my glasses, unfortunately. As Dr. Morris had suggested, there is a need to follow up with the STAMPEDE study because of its excellence and its broad base of foundational data.
So I wonder if there have been any conversations about the DoD contractors as a risk group, and perhaps, one of the higher risk groups. The other comment about that is that we have some deployers who have left active duty and then work for contractors. And so there's, some crossover between these two groups, and that just seems like a very high exposed occupational group in our experience, and I wonder if you all have thought about how to capture that population.
From a DoD perspective, they're not eligible for care within our system, so we don't see them, and we have no way to capture anything on the contractors. I don't know from the VA. The few that I have seen came out of Karmat Ali and the program they set up to look at that exposure back in 2003, but those are the only ones we're allowed to see. So.
All right. Oh, go ahead.
On the VA side, we have a similar restriction. The patients we see must be eligible for VHA care, and so it's contractors, unless they're also had military service, we would not be able to see them.
And I don't know what the percentage is, but there's certainly some. So in the context of capturing exposure, it probably is important, and I don't know whether there are mechanisms of doing that or even really how commonly that occurs, but I just raise it as a potential confounder.
Yeah, it's an interesting question. I mean, for the Millennium Cohort, we draw from DMDC rosters, so contractors would not appear in that. And we have thought about contractors from an exposure assessment viewpoint, and it's something, and I haven't really considered that until you point that out, but is it something that could be asked in a future survey about contract experience subsequent to military service?
We're asking about contractors. We're asking that question, and we're asking about different exposures, although we're not going on contractor location, if you would, but that would be something to be think of.
Last question.
Well, okay. I guess I have two questions. All right, a comment and a question. I'm concerned that if we continue the way it's going, we're going to be here in 10 years doing the same thing over again, because without actually planning a study and separately funding it, it's not going to be so easy to deal with the convenience samples that many of you have. But I want to come back to Dr. Garshik for a minute, because using a 1x1 km grid from the satellite data now is certainly available and possible. But there probably are grids that are wider, perhaps, six. I think there's a 6 km grid.
You're a wider.
Pardon?
Yeah, there are wider.
Yeah. That go back a number of years. And I'm wondering whether, first, by validating that the 1x1 versus the 6 would be a first step. But if you could show that you could, and I guess they're 1 month versus daily or whatever they are, the differences. If you could validate that the 6 is close enough, it seems to me you could supply all these people with data that go back to the years of exposure that people had. And I'm wondering whether that's been thought about at all with Petros.
Well, the 1x1 grids are going back to 2001. So yes. Yeah. That's the goal, is to do that from the beginning of the conflict.
Let me thank the panel for a very interesting morning. Very informative, and surely will be useful to the committee. I'm hoping Dr. Spicer is incorrect in that we're not asking the same questions 10 years from now, but only 10 years from now will tell. Thanks very much for a very